Chapter 22, Care of Patients with Head and Spinal Cord Injuries. The mildest form of a traumatic brain injury is a concussion. The coup-contre-coup injury, or the acceleration-deceleration injury, occurs when the head is moving rapidly and hits a stationary object, for example, a windshield in a car accident. The contents inside the cranium hit the inside of the skull, which is the coup, and then bounce back, hitting the bony area opposite the side of the impact, causing a secondary injury, which is a contre-coup. If sustaining a secondary concussion within 10 days, this will put the patient at risk for long-term problems. Most healthcare providers will not permit the resumption of activities that could produce a concussion for 1 to 2 weeks after the symptoms have subsided. Two different tests to determine brain functioning is the electroencephalography and an MRI. The nurse is admitting a patient with a possible periorbital fracture, which clinical finding would likely confirm the diagnosis. Battle's sign, partial blindness, ortorrhea, rhinorrhea, swallowing difficulty. The answer is 1, 3, and 4. A basilar fracture is linear and occur in the bones that cradle the brain, which is the base of the skull. Because of the location, the fracture of the bone cannot be seen on a standard imaging. The fracture is diagnosed by clinical signs of cerebral spinal fluid, or CSF, leak, or bleeding into structures. With ecchymosis, it may occur around the eyes. This would be known as raccoon eyes. Ecchymosis behind the ear is known as a battle sign. These are both indicators of basilar skull fractures. A fracture is considered open when it allows the brain and the meninges to be exposed. An open fracture of the skull requires immediate intervention. A hairline fracture is a linear fracture or a crack. If the fracture crosses a vascular channel, a blood vessel may be damaged, resulting in bleeding. Fractures that do not cause bone displacement are left to heal without treatment other than what might be needed for the injury to the brain. A contusion is when the brain tissue is bruised, blood from broken blood vessels accumulates, and edema develops. A subdural hematoma is a common result of a head injury. When a blow is delivered to the head, blood vessels will rupture that lie between the arachnoid membrane and the tough fibrous dura mater. The blood leaks under the dura mater, making it subdural. The hematoma will become larger and press against the brain tissue. A subarachnoid hemorrhage occurs due to traumatic brain injury. The subarachnoid space is where the CSF circulates. Bleeding into here circulates blood throughout the spinal dural sac and predisposes the patient to developing hydrocephalus. In the images seen, A is a subdural hematoma. This is due to a result of trauma to the head. Small ruptured blood vessels leak blood into the space under the dura mater. It is slower than an epidural bleed. B is an epidural hematoma, the result of a head injury that tears a large meningeal artery and has caused a rapid bleed with a large amount of blood above the dura mater. If it is not relieved, the subdural and the epidural hematomas may be fatal. C is an intracranial hematoma. Small vessels within the brain have torn and are bled. With any skull fracture, the number one concern is the level of consciousness. The patient may be alert and respond appropriately to questions and commands with little stimulation. The patient may be confused, somewhat disoriented to their surroundings, time, or people. Their judgment may be impaired. The individual needs to be cued to respond to commands. If the patient is lethargic, they will be drowsy but easily aroused. They need gentle touch or verbal stimulation to attend to the commands. If obtunded, it is more difficult to arouse the patient and they respond slowly to stimulation. They need repeated stimulation to maintain attention and to respond to the environment. Stuporous is when the patient responds to vigorous stimulation only slightly. They may only moan or mutter in response. If the patient is comatose, there is no observable response to stimulation. If a skull fracture has occurred, the number one issue that the nurse is aware of is potential increased intracranial pressure. We want to make sure that the patient's airway is patent, and we raise the head of the bed 20 to 30 degrees, keeping the body in the correct alignment. We will monitor the neurological signs very close. Brain bleeds require immediate surgery. After surgery, we want to position the patient with the head of the bed at 30 degrees and keep the body in a correct alignment. We will prevent constipation, provide pain control, and we will report any neurological status changes to the physician. The image shows cerebral spinal fluid in the outline of the image, and the center is blood. The Monroe-Kelly doctrine indicates that 80% of the cranial vault is taken up by brain tissue, 10% is by cerebral spinal fluid, and 10% by cerebral blood flow. If any of these three elements increase, then the pressure will rise. Papilledema, or the swelling of the optic disc, is viewed with an ophthalmoscope. This is a classic sign of increased intracranial pressure. The patient may have the following symptoms: headache, nausea, and/or vomiting. With increased intracranial pressure, diuretics will be given to help relieve the fluid that is inside the brain. The patient may need to be on a ventilator with oxygenation support, and the nurse will help control the temperature. When intracranial pressure rises, it affects the oxygenated blood perfusion of the brain, and tissue hypoxia occurs. An extended period of hypoxia can cause brain cell death. Brain tissue swells or volume of fluid increases in the cranium. Damage occurs or pressure is placed on the oculomotor nerve, or the third cranial nerve. The pupils begin to react slowly. The pupil size will become unequal, progressing to dilation, and then the pupil size will become fixed as the reflexes disappear. There are classic signs of increased intracranial pressure. The first three of these are called the Cushing triad. Number 1, rising systolic blood pressure. Number 2, widening pulse pressure. and number 3, bradycardia with a full bounding pulse. These are the Cushing triad. Other signs include rapid or irregular respirations. Hydrocephalus is an excessive accumulation of cerebral spinal fluid. This may occur causing motor deficits, cranial nerve deficits, or decreased cognitive abilities. Diabetes insipidus may occur from an injury or edema of the pituitary gland. Antidiuretic hormone is released in inadequate amounts, causing polyuria, and the awake patient may complain of polydipsia. Any increasing intracranial pressure needs to be reported to the physician. The patient may experience a headache, vomiting, an unequal size of the pupils. There may be leakage of cerebral spinal fluid from the nose or the ear, and you may note a change in blood pressure, pulse, or respirations. For nursing care, we want to make sure that we help maintain the normal functions of the body. We want to protect our patient from injury. We want to make sure they have adequate respiration. We assist to reduce the intracranial pressure, and we want to prevent any further complications. Automobile accidents, gunshot wounds, diving accidents, falls, and other forms of trauma often inflict severe damage to the spinal cord. But tumors, degenerative disease, and infections can also impair the functions of the spinal cord and its branches. Spinal cord injuries are classified according to the anatomic location, which would be cervical, thoracic, lumbar, or sacral. Complete spinal cord injuries result in the loss of function below the level of the injury. An incomplete spinal cord injury will result in varied degrees of functioning and sensation. Severe injury to the spinal cord above the level of the 5th cervical vertebrae is often fatal if emergency care is not provided immediately, because the phrenic nerve that innervates the diaphragm originates in the 3rd, 4th, and 5th cervical segments. The branches of the nerves play a major role in control of respiration, and when they are severed, respiration must be maintained by artificial means. To avoid flexion of the individual's neck, there is to be no pillow or other support placed under the head. The patient is not to be moved unless life-threatening conditions are necessary. Accidents can cause vertical compression on the cervical or the lumbar spine. Microscopic bleeding occurs in the gray matter immediately after an injury. The irritation of the brain cells causes edema to develop and then spread along the next 1 or 2 cord segments. Edema will peak in routinely 2 to 3 days and will subside in about 7 days after injury, and causes temporary loss of function and sensation. A 40-year-old man with T4 spinal cord injury suddenly complains of severe headache, increased pulse rate, sweating and flushing above the level of the spinal cord lesion, and goosebumps below the level of the injury. Immediate nursing actions would include: place the patient flat in bed, identify the cause of the stimulation, administer antihypertensives, provide measures to facilitate a bowel movement, or clamp the indwelling catheter. The answers are 2, 3, and 4. A cervical spinal cord injury with subluxation is usually treated with traction to immobilize the affected vertebrae and to maintain alignment. Crutchfield tongs are used for cervical traction. The halo traction vest is used for cervical stabilization. The halo traction brace immobilizes the cervical spine. This RotoRest Delta Advanced Kinetic Therapy bed allows the patient to be moved by tilting the bed or raising various aspects of the bed to keep the body in correct alignment. By sustaining a spinal cord injury that causes permanent neurologic deficit, it brings with it many losses. Many patients experience grief and mourning because of the losses experienced and the changes that the losses bring to their role and their lifestyle. Preventing back pain and disorders begins with proper posture and the use of correct lifting techniques. Maintaining one's weight within normal limits will also help decrease back strain. In the image, it illustrates a herniated disc with compression of the spinal cord. Initially, back pain is treated with conservative measures in the hopes that surgical correction will not be necessary. If the pain does continue beyond 3 to 4 weeks, or if the pain is worsening and there is an evidence of neurologic deficit, surgery may be indicated. A spinal fusion is the most common surgery that is performed for low back pain. The disc between the vertebrae is removed and the vertebrae are fused together. A discectomy is performed to decompress the nerve root. There are a few complementary and alternative therapies that can be used. Acupuncture uses small sterile needles to decrease chronic back pain. Acupressure, which is like massage pressure, relieves muscle spasms, and massage therapy also assists in relieving muscle spasms. Injuries of the spine require that log rolling be used, and it is done with extreme care to avoid twisting the vertebral column and further damaging the spinal cord. As a nurse, the number one injury is low back injury. We need to make sure that we understand how to use proper body mechanics when we are moving patients, moving equipment, lifting items from the floor. With low back pain, there are things that should not ever be done. To bend over without bending the knees. Reaching to lift items or heavy items higher than the elbows, sitting or standing for great periods, sleeping with your legs out straight without a pillow cushioning under the thighs or between the legs when on the side, bending from the waist to pick up an item, or twisting to lift packages or other things.